Hello and welcome to COPD Wellness. We're your hosts, Angus and Russell, and on this podcast we talk to medical professionals and COPD patients to discover just what living with a lung disease is like, the effects it has on you mentally and physically, and how it affects those around you. In this week's podcast, Russell will be chatting to his doctor, Dr. Wayne Kelly, a respiratory specialist based in Brisbane, Australia. Wayne has years of professional experience in the respiratory world and will help shed a light on COPD diagnosis, medications, and pulmonary rehabilitation. This episode is proudly sponsored by the National Asthma Council of Australia.
Okay, so we're here today. We're in the offices of my own respiratory doctor, Dr. Wayne Kelly, where it all started for me, so I thought it was a good place to start. Dr. Kelly, thank you very much for availing yourself of some time today for us.
My pleasure.
I guess for the audience at home, the first thing we want to talk about is your qualifications, your experience in the respiratory world.
Respiratory and intensive care specialist. I started out initially to train in intensive care, and when rotating through respiratory, I decided that was very worthwhile and interesting part of clinical practice, and continued in it.
Okay, so how long ago would that have been? Or should not ask?
I've got a grey hair, I've been at it a while. I obtained my qualifications in 1984, actually.
Okay. So it's fair to say you've got a bit of experience.
I have. I've worked hard for these grey hairs.
So have you ever thought of going away from respiratory medicine, or it's always held an interest for you?
Oh, look, it's always held an interest, and I think respiratory medicine applies both in community practice, occupational lung disease. It certainly has a role inside hospital medicine. In Indigenous medicine, there's a great need for respiratory, and I've worked in a variety of those areas in my time.
Do you find, speaking of Indigenous communities, that those remote areas, are they ones that really struggle to get the services they need?
Well, look, I'm speaking personally from my own experience, and the answer to that's yes. They are remote in terms of distance, so access either by road or air is limited. Flights in and out, be they commercial or chartered, therefore tend to be expensive. And coordinating clinics in parts of Queensland, for that reason can be quite difficult.
And I guess that would apply to anywhere in the world. Remote communities are all going to have the same sort of challenges, I guess.
They do, and speaking to friends who have worked in communities in other continents for short periods of time have come across exactly the same sorts of problems that we face here in Australia.
I guess starting from the start of diagnosing a patient, I get a lot of patients contact me and tell me their stories of how they diagnosed, and sometimes I scratch my head. And I don't have any training in respiratory disease. I only know what I read and what you've told me over the years. So a patient's referred to you, knocks on the door. Where's the starting point as far as diagnosing?
I think historically, doctors and the lay community would often think of chronic obstructive lung disease, or as we call it now, COPD, purely the end result of smoking-induced lung disease. And we know that that's not true, and that unfortunately patients can develop COPD through a number of lung insults. Having said that, in this part of the world, cigarette-induced lung disease is still the number one cause for COPD. But if you live in other parts of the world, in third world countries, exposure to, even smoke from household stoves and fires.
Wood fires, that sort of thing.
Exactly. Is a big cause of COPD. So these days, be it if a patient is going to their general practitioner or they're coming to see someone in a respiratory clinic or in their offices, the history is paramount. The occupation of the person, exposures they may have had growing up, because we know now that respiratory insults during childhood, when our lungs are growing, can have an adverse impact on where our lung function finishes up. And hence, trying to avoid secondhand smoke exposure for children is very, very important. So the history is important. Are they a smoker? Have they been a smoker? We try to quantify their smoking history, and doctors will often talk about a pack year. A pack year is when patients have generally smoked 20 cigarettes a day for a 12-month period. That would qualify as a one-pack year. And there's very good evidence that when patients have accumulated more than a 20-pack year, their risk of developing a number of problems from COPD or lung cancer start to escalate. By its name, chronic obstructive lung disease means they've got obstruction to airflow, and so simple tests of lung function that we call spirometry and required to confirm a diagnosis of COPD.
Okay. So a patient goes to their respiratory clinic, they have spirometry testing done, and that is the gold standard as far as diagnosing COPD, for instance?
Yes, it is. So patients may, for argument's sake, with asthma that is not well controlled, when they have their initial spirometry test done, have what we term as airway obstruction or airflow limitation, but with a course of intensive treatment, you may find over a period of months that their respiratory function improves and in fact normalises. And so COPD implies that there is fixed or irreversible airway obstruction as a consequence of, in most situations in our society, smoking.
So there's been some talk about the importance of CT scans in far as diagnosing COPD. I'm not an expert, but from what I know, a CT scan is more to show the damage in the lungs and doesn't necessarily show the obstruction and the amount of obstruction in the lungs. Would that be?
Look, I think as a general comment, that's quite true. I mean, I often talk to patients about assessing their pulmonary function, which we do through lung function testing, and looking at their pulmonary structure, which you can do on a CT scan. Unfortunately, patients who have smoked may not only develop COPD, but are at risk of lung cancer. And so the patient who presents with COPD statistically has a high risk of having an accompanying cancer. There is a role for using CT scans, but a simple chest X-ray and office spirometry for the majority of patients provide enough evidence, if you like, to commence treatment.
Okay. So when we look at patients who, going on another part of the disease, suffer from oxygen desaturation, so how does that fit in with diagnosing COPD? Does that show up on spirometry testing?
No, that's a very good question. So what we know is that we have a scale, or we assess the degree of airway obstruction in terms of percent predicted. So if we were to have 1,000 Russell Winwoods who did lung function testing, we would come up with a range of values that we would regard as the normal range. And it's when patients fall below that we believe, and not always necessary, that there's increased likelihood of disease. The more severe the obstruction on spirometry testing, the greater likelihood that patients have quite abnormal, we talk about gas exchange. So the lungs basically, when we are breathing, take up oxygen and excrete the carbon dioxide that our body makes as a byproduct from our metabolism. One of the simple ways that we have in our office these days are using pulse oximeters, which simply look at the colour of blood going through a patient's nail bed, and the more full the blood is of oxygen, it changes the colour. So you can infer that if someone's got very reduced lung function, that he or she may be hypoxic, which is a term for reduced oxygen saturation, but it's not a hard and fast guide, and so we would normally go on and do at least some simple pulse oximetry. The other part of the problem becomes that often when patients at rest, they are not hypoxic. However, with simple daily activities, showering, making their bed, walking up the back stairs, putting their washing out in the clothesline, that in the situation of increased ventilation, the lungs' inefficiency to exchange gas becomes apparent, and so their oxygen levels will start to drop off and they'll become hypoxic.
Okay. So, and I mean, it's going to be different, I guess, for every patient. I mean, I'm an example of someone who generally in day-to-day life doesn't have a problem with oxygen saturations. However, when I'm at altitude, whether it's in a mountainous area or obviously when I'm flying or travelling, I suffer from desaturations. Is that hard to sort of work out which patients are going to have that problem and which patients aren't? And is there a unified test that you just do all along to work that out?
Look, as a general rule, the more severe the airway obstruction, the greater the likelihood that the patient will become hypoxic at altitude. And by altitude, I also mean airline travel. As a general rule, looking at simple pulse oximetry, so if pulse oximetry gives a normal reading, the patient is fairly unlikely to become hypoxic with travel. Over the years, there's been a number of studies done trying to correlate a measurement of lung function called the FEV1. The FEV1 is the volume that a patient can forcefully expire in 1 second. And so the FEV1 was incorporated into different equations to try and predict which patients, when they were flying at altitude, would now be quite significantly hypoxic. That is not always the case, and so there have been developed a number of tests, one which is called a hypoxic altitude simulation test, and in that test a number of lung function laboratories will get patients to breathe a reduced concentration of oxygen, similar to what would be in an airline travelling at around it'll be pressurised to 6,000 to 7,000 feet, so the plane's at 40,000 feet, but inside the aircraft the ambient pressure is at 6,000 feet, and so you're trying to put your patient at that altitude but have it in a lung function lab. And so what we're trying to work out is which patients are going to need supplemental in-flight oxygen if they're going on prolonged travel.
Mm-hmm. And I guess that's where I found with my diagnosis. We did the altitude test and I significantly desaturated under those circumstances, which I always have found interesting in that scenario, how I do saturate so quickly, yet in normal day-to-day life, walking around, I don't have any problems. But, you know, I guess that's the difference between the diseases. Not everyone's disease the same, and everyone has different symptoms.
If you take a healthy non-smoker and they're on an international flight, their oxygen saturation will certainly be lower than it is at sea level. The difference is it's still at a safe level, but perhaps not the normal sea level. For patients with advanced COPD, they may have a safe level at sea level, but in a jet now on an international trip will fall below that level, hence requiring supplemental oxygen.
Alrighty, so talking about COPD, which is an umbrella term for a number of different diseases, what are some of the diseases that fall under that term?
Well, unfortunately, asthma that has been suboptimally controlled over a number of years may result in fixed irreversible airway obstruction. So patients may have had asthma from their childhood, they may develop asthma in later life, but for one reason or another it has not been satisfactorily controlled, and they may end up with fixed irreversible airway obstruction. Unfortunately, patients in different industries, again, who may be non-smokers, but by virtue of what they're inhaling, will cause lung damage. There's a number of other conditions that we'll see in the community to a variable extent. One that will often present in adults is called bronchiectasis. This is different to the bronchiectasis of cystic fibrosis that will present in childhood. So these patients have often had repeated infections, lung damage over many years, resulting in reduced pulmonary function. There are some rare forms of emphysema, one in particular called alpha-1 antitrypsin, and this can present with airway damage and obstruction, even in people who have been healthy non-smokers.
Is that more of a genetic version? Would that be right?
Yeah, it is.
Yeah.
And, you know, as I said, it does run through families, and been involved in looking after two brothers who have rather alpha-1 antitrypsin deficiency.
Okay. Is that becoming more common, or does the numbers really stay the same? Or?
I think that the numbers have stayed the same. It's possibly being diagnosed more frequently because there are blood tests available to measure the protein level in the bloodstream, which is a marker for this condition. Similarly, with the advent of CT scanning, that the pattern of emphysema in this congenital form is somewhat different variant to cigarette-induced emphysema, and so the radiologist may alert the referring doctor to the possibility of this diagnosis.
Okay. Moving on to medications, has much changed in what's available for patients over the last, in your case, 33 years, if my maths is correct?
Well, going back to the cave, we had a limited number of medications, and historically, Ventolin was present in the late 60s and 70s, and it's still there, and it's still a very good drug, it's salbutamol. It's now marketed, obviously, by different companies. Inhaled corticosteroids were coming onto the marketplace. One was called beclomethasone, which the trade name then was Becotide, and these days is still available in the workplace, in the office through different names. One that springs to mind is Qvar. There were non-steroid prevented drugs such as Intal, and again, it's still there, and for some people serves a role. There were a group of drugs called the Atrovent, which is again still around, ipratropium. It was, if you like, the parent of tiotropium or Spiriva. So they were the main drugs. I suppose there was oral corticosteroids, prednisone, dexamethasone. They're still there, and they serve a very important role. And I suppose a drug that still we will use in some patients is aminophylline or theophylline, a weak bronchodilator, but for some patients is often quite valuable. So the armamentarium has certainly increased, but the actual classes of drugs from terms of bronchodilators and inhaled corticosteroids and the long-acting muscarinic agents have evolved from those drugs.
So when a patient is diagnosed with COPD, are they likely to go on all types of all the frontline medications, or there's some that work or more specific to a certain disease, if that makes sense?
Let's assume that we've got a patient who presents with COPD, who has been a heavy smoker, and that he has been in clerical work, and there's nothing to suggest an occupational component to his disease. And so, in other words, this is likely to be cigarette-induced COPD. A number of societies, both in Australia and overseas, have put out guidelines for the introduction of bronchodilator therapy. So initially what we term short-acting Ventolin type of drugs, Bricanol or Ventolin, Asmol, or using a anticholinergic agent such as Atrovent. These days, however, there's certainly a trend to using the longer-acting forms of the beta agonists or the longer-acting forms of the muscarinic antagonists. And as I'm sure you're aware, there's several out there, different trade names, Sebree, Spiriva, to name two.
Yeah, I mean, and it seems to vary from country to country. Now patients will tell me they're on a certain medication. When I look it up, it's the same as I'm on. It's just a different name in a different country. Okay, so the next topic is one that I'm a big fan of, as you know, is rehabilitation, pulmonary rehabilitation and exercise. So when you diagnose a patient, is there patients that are suitable for pulmonary rehab versus ones that aren't, or are all patients suitable?
That's a very good question. I think all patients are suitable for a pulmonary rehab program. And again, there's a number that are well established. I'm talking here obviously about Brisbane, both through Princess Alexandra Hospital, the Prince Charles and the Royal Brisbane, and they try and address both the general well-being of the patient, aspects of dieting, physiotherapy, medications, etc. They're run as outpatients, and there's very good published evidence that point rehab programs, for instance, keep people out of hospital. So trying to get, and the patients often get a little bit put off that they're going to be referred to a rehab program, but the exercise program is tailored for them. It's not tailored for someone who's got normal respiratory function, so it's tailored for a patient with impaired lung function. And I'd have to say, in my experience, the majority of patients who have been through the rehab programs find them of great benefit, and that the main problem is in keeping those patients motivated and keeping up their exercise program.
And that's something I've come across a lot. I mean, I consider myself lucky. I've always been active from childhood, so sport is something, or being active is something I like to do. But there's plenty of patients out there who have not led an active lifestyle, so to all of a sudden confront with having to go to a pulmonary rehab class when they don't like exercise for the start, and they're quite sick, that's challenging. So in saying that, is there ways that we can keep those patients active after pulmonary rehab?
Well, set up in the community now are a number of facilities where patients can continue to, if you like, exercise away from hospital-based programs. Several of the programs have telephone follow-up. Some, I think, also have nurses who are community-based who will maintain contact with the patients and try and encourage them to continue to exercise. It's often these sorts of scenarios important to have family members go along and see what's being undertaken and try and encourage, their husband, wife, mother, father, whoever it is, to keep doing the program, because there is long-term benefits. It's very important, and not to become a couch potato.
Mm. So going on from that, so an incentive for people who are listening to this today, and maybe they've been through pulmonary rehabilitation and not gone any further, if a patient does keep exercising or keep active after that, could they see an improvement in their symptoms? Are they going to become more and more active to a certain extent, obviously, depending on their disease?
The amount of improvement that patients get can have a potentially number of limiting factors. So, for argument's sake, if patients have peripheral vascular disease, if they have accompanying cardiac disease, they may limit the amount of activity that patients can undertake. Certainly for patients who have got very severe COPD, the amount of benefit or the amount of exercise they can undertake can certainly be limited. Some patients need to have supplemental oxygen when they're doing exercise, and that can certainly be arranged for the appropriate patient.
Mm. Well, on that, the equipment that's available these days, and I've been using, not that I need it, just so I can show other patients, portable oxygen backpack. So you can go for long walks, you can go for bike rides, and you can do all sorts of things, and you've got your supplementary oxygen with you. Obviously, it's got its limits to how much oxygen it can provide the patient with, but I think those sort of devices certainly help encourage patients to get out there and keep active.
I must say, just in my own experience, I went to a meeting in Denver several years ago, which, to tell your listeners, is actually at 5,000 feet altitude. I've never seen so many people in my experience walking around the streets with supplemental oxygen, because they are living at a higher altitude. Therefore, the oxygen concentration that they're breathing in is reduced compared to being at sea level. And I was chatting to a fellow in a cafe, and he had moved to Denver from California, and one of the things he suddenly found was he now had to be on oxygen 18 hours a day, whereas in California he wasn't. But that was he moved up there for family reasons, and So we probably at sea level a little bit better off than people living at such altitude.
So in that scenario, so there could be people wandering around who have a lung disease of some type and not really know they have that lung disease.
I suppose that's possible. It depends how frequently patients stay in touch with their general practitioners, and there's a lot of information I think out there now on the web or on TV shows or etc. talking about COPD and asthma. So I think if patients suspect they may have a chronic respiratory condition, I'd encourage them to go to their GP and ask the question, could I have COPD?
Exactly, there's no harm in asking, and as we know, the quicker a patient can be diagnosed, then the better outcome they're going to have. One thing I sort of rave on about with articles I write, because I think it's important, is for a patient to actually educate themselves. And I talk about asking questions of their doctor, which I'm sure you're sick of me asking questions of you, but that sort of thing. Do you think it is beneficial for a patient to engage with the progression of their disease and know more about it rather than just assuming that their healthcare professional will look after everything and that'll be that?
Look, I think you raise a number of issues. I think patients need to be informed. I think the medical profession should inform the patient, irrespective of whether they've got COPD or diabetes or chronic kidney disease. In terms of COPD, for argument's sake, the patients know why they're taking certain medications, what's the evidence for these medications, things such as inhaler technique. A lot of patients, either with asthma or COPD, can't correctly use their inhaler, so if the medication doesn't get into the airways, it's just not going to work. We talk to patients about having a management plan or an action plan for when there's a flare or an exacerbation in their disease. I often tell my patients, and I talk about this, the what-if scenario. What if I get a cold and I start to bring up dirty phlegm? What do? I'm starting to get short of breath and wheezy. What do I do? So I think we have to educate our patients that they know what the strategy is. Unfortunately, COPD is a progressive condition. Patients who have COPD may have other medical problems. They may need total knee replacement. They may need prostate surgery. So their COPD has got to be managed in that perioperative setting as well. So, it's certainly up to us to often prepare patients for problems that may develop in the future. Again, simple things like making sure the patients have received the influenza vaccination and, if appropriate, the pneumococcal vaccine. So, education doesn't stop. Newer treatments come out. They're not always applicable to all patients, and it's reasonable for patients to have the conversation with their GP or their respiratory specialist about advances in medicine.
On that topic, the future of COPD medications and treatments, where do you see that going? I should say that, especially where we still have basically the same products that we've had for many years. Are we looking at a new type of product that's going to enhance a patient's well-being?
Look, I think there's, as you know, a number of long-acting medications on the marketplace that also have a corticosteroid in them, and people talk about the triple therapy, the puffer that's got a corticosteroid type of drug, a long-acting Ventolin type of drug, if you like, and a long-acting Atrovent type of drug. So the LAMAs and the LABAs, as the terms go. And they've certainly been shown to improve quality of life, to reduce frequency of exacerbations. There are some anti-inflammatory medications that have been developed, and the hope is that these may reduce airway inflammation and progressive damage, but some of these are still in the experimental stage. There is a small group of patients who may be suitable for certain forms of thoracic surgery. This sort of goes under the topic of lung volume reduction surgery, where the more damaged parts of the lung are want a better word, deflated or removed. The aim being to allow the less severely affected parts to function more effectively. We worry about, obviously, the development of lung cancer because cigarette smoking is a very common and important risk factor for lung cancer. So, screening these patients or following them up for that possibility is also very important.
It is, and with patients, let's say a newly diagnosed patient, I mean, I guess it's going to depend on their lifestyle, but what would be the best advice you could give any patient as far as things they could do to better their quality of life?
I think the most important thing is to stop smoking. I think you stop smoking, you have your respiratory function assessed, either by a GP or a specialist. GPs can refer patients to pulmonary function laboratories for testing. You get the patient to go off into a pulmonary rehab program and then stick to the advice that they get out of that. Is that 3? I'm not sure if I can think of any. And probably, unfortunately, we know that patients with COPD have a high risk of associated cardiovascular disease. So I think that that question has often got to be looked at, and sometimes it's forgotten when there's been such a focus on the respiratory symptoms.
Okay. And I guess a question that I think I'll probably end every episode with, depending on who I'm talking to, if Dr. Wayne Kelly was diagnosed with severe COPD tomorrow, what would you do?
I would optimise my bronchodilator therapy. I'd make sure my vaccinations are up to date. And I would like to make sure I didn't have accompanying or occult coronary artery disease. And then I try and stay fit and try and stay happy.
Well, there you go, folks. Some great advice from an expert of 33 years. I keep drumming on that to make him feel old. Wayne, I won't tell you what he's doing right now. Wayne, I'd like to thank you today for your time. It's been very interesting. I'm sure a lot of people will get a lot out of this. And thank you very much.
Thank you for asking me.
No problem at all.
Thanks for listening to today's episode. Remember, you can follow COPD Athlete at COPD Athlete on Facebook. You can connect with Russell on the COPD Athlete Facebook page or check out copdathlete.com.
Be sure to tune in next time when we continue to explore chronic obstructive pulmonary disease.
Thanks for listening. We'll see you next time.
Bye for now.